Okay, guys. Now, the heart will pump deoxygenated blood to lungs, correct?
Yes. Wait,
It will
the
go
oxygen? Yeah.
deoxygen. Deoxygenated blood will pump it to lungs.
Dr. Moneer, what are we doing now?
Now it's circulation, pulmonary circulation. Please. Pulmonary circulation. Pulmonary circulation. Okay. So blood is pumped into the pulmonary trunk. From there, we'll go to pulmonary arteries, right? Pulmonary arteries will bring this deoxygenated blood to lungs. But guess what? Now, the pulmonary arteries and its branches will follow the airways. Will follow the airways. What do I mean by that? Yeah. It will travel parallel to the bronchi. So it will give a branch here. So if it's splitting here, it will give a branch this. It will go to the appropriate locations. And eventually reaching, very good, the alveoli. So the pulmonary artery will keep splitting and splitting and splitting, just like the trachea. Okay, or the primary bronchus will keep splitting, and eventually, so now this will split into many capillaries, circulating around the entire alveoli, and as it acquires oxygen, it will become red, correct?
Mm-hmm.
So let's do that. So the idea here is pulmonary arteries follow airways, the division of airways. Yeah.
So that means that pulmonary blood is not distributed equally?
Nope, it's not.
Okay.
Because the gravity, remember we're talking about. So now, and then pulmonary vein, remember, pulmonary veins will start as carrying oxygen and blood, and eventually, but they don't follow the airways. So they will eventually join all of them. It will become pulmonary artery, and coming to the left, atrium. So eventually they will become pulmonary artery. A bunch of them will group together, right? So it become two pulmonary arteries. From left and two from right. I mean vein, sorry, pulmonary vein. Okay, so pulmonary vein. The difference is pulmonary vein does not follow. Pulmonary veins does not follow the direction of airways. Okay. But so now you can focus on this area. Let me color with yellow. This is a single alveolus. Look what alveolus is made of. It's an air sac surrounded by a network of capillaries. Okay? This network of capillaries is made of pulmonary artery, branch of the pulmonary artery, and pulmonary vein. That's where the gas exchange will take place. Okay, good. So, you know what pulmonary arteries come from. They originate from lung, from capillaries. Whereas pulmonary arteries come from the aortic trunk. So these are the vessels or pulmonary circulation that is only used for gas exchange. Their job is not to provide oxygen to the lungs. It's only to carry oxygen away from lungs and bring carbon dioxide to it. So now, the next thing, you have aorta. Aorta, let me erase this. It's making me messy. Messy. So let's say this is aorta. So aorta will give you branches. It gives you branches known as bronchial arteries, not pulmonary, bronchial. So these arteries, branches of aorta, directly supplies the tissue of the bronchiole. It delivers oxygen to bronchiole itself. So bronchial arteries, they're not used for gas exchange. Their purpose is to provide oxygen to airways and lung itself. Okay, alveoli, alveolar duct, they can get oxygen through direct diffusion, but airways can't. So pulmonary circulation is made of pulmonary vessels, which is arteries and veins, and bronchial arteries. Bronchial arteries carry oxygenated blood. Pulmonary artery carries deoxygenated blood. Pulmonary veins carry oxygenated blood. Good? Pulmonary arteries come from pulmonary trunk or right ventricle and ends in alveoli. pulmonary veins originates from alveoli and ends at left atrium. Good? Okay. All right. In this context, now what do you think? Pulmonary circulation is slightly different. So if this is a pulmonary capillary or vessel, how would oxygen, pressure of oxygen affect this pulmonary blood flow? What do you think? Should increase in oxygen cause vasodilation or vasoconstriction in these areas, in lungs? So let's compare pulmonary circulation to other tissue, non-pulmonary, okay? So a blood vessel in lungs, or pulmonary capillary, I should call it pulmonary capillary, that's much better. Pulmonary capillary or pulmonary capillary or capillary, and then you have non-pulmonary capillary. So tissue, other tissue. Okay, good. Both of them are regulated by oxygen to some extent. What is the effect of increased oxygen? And what it should be, forget what it is. And what would be the effect of increased oxygen, partial pressure of oxygen on tissue capillary? What do you think? Good. So what should happen in lungs when you have more oxygen? What should happen to those vessels? Dilate. So it causes dilation. And what should happen to tissue blood vessels when you have a lot more oxygen? Nope. It doesn't affect it, but it doesn't affect it. So this, let's say, no effect. Now let's talk about hypoxia, which is low oxygen, correct? That's more important. How does hypoxia affect capillary, and how would hypoxia affect pulmonary vessels?
Tissue will cause dilation.
Very good. Here, in tissue, it causes dilation. Very good. And constriction here. To an extent, yes. Very good. What did she say? She said, don't tell Safe what I said. She said, this is Bohr's and Halliday's effect. I said, yeah, to an extent. Okay. Now, why would that be? Yeah. So,
If you have low oxygen, you want to restrict the capillaries because you want to increase the oxygen in certain parts and not have the oxygen diffused throughout all of the capillaries throughout your lungs.
Will shrunk the blood towards the area of higher oxygen.
very good. Yes. Remember, lungs have 3 zones. Zone 1, 2, 3. When we talk about the right lung. Now, if you have hypoxia, less oxygen, do you want to waste sending blood to the lower lobes? So you're going to cause vasoconstriction here, here. So most blood can go where? To the upper lobes, so you can get more oxygen. So hypoxia shunts blood to those zones that are mostly ventilated, hyperventilated. Does it make sense? In lungs, it's the opposite of tissue, because in lungs, when you have less oxygen, you don't want to waste perfusion of those areas that have no oxygen. So you're going to shunt blood to those areas that have more oxygen, upper zones. So in lungs, hypoxia will always cause vasoconstriction. Will always cause vasoconstriction, especially in the lower lobes. Selective vasoconstriction. Now, yeah.
So that means that because you're shunting it to the lower parts of the lung?
Nope, upper parts.
Or you're shunting, okay, so you're shunting it away from the lower parts?
Yep.
So in the upper part?
Mhm.
So that means that you can more easily get oxygen to another part of the body?
Okay, let's do
Is
that.
that why?
No, other parts of the body, ignore that.
Okay, so
Okay, let me
because
do.
hypoxia is absence of oxygen, right?
Yep.
So
It will make
I'm
more
like
sense.
still slightly confused.
You're so slightly confused.
Yeah.
Good. Which area has the most oxygen?
3, 1. 1. Time out. Blood flows 3.
So here you have the most oxygen, correct? So I'll put 3 arrows. Is that okay?
Yeah.
In here you have,
Medium.
okay. In here you have, okay. Now, let's say you have less oxygen coming. For whatever reason, like in COPD or people who are smoke or whatever, they have obstruction or tumor or whatever, there's overall less oxygen coming to lungs, correct? So if less oxygen is coming, that means there's hypoxia all over the lungs. But relatively speaking, where would you have the most hypoxia? So the most hypoxia you will have here. And let me put here 3 arrows. The most hypoxia. 2 arrows. And you will have 1 arrow hypoxia. Now, hypoxia in this case means lack of oxygen, right? It doesn't mean increased oxygen. So what would you have the most vasoconstriction? In the bottom. So most vasoconstriction, so vasoconstriction is higher here, and the medium here, and least here. Does it make sense? So it's not just like you saying like, oh my God, somehow there's vasodilation. There's vasoconstriction all over the place, depending on the severity of hypoxia. As long as you understand, it is hypoxia that causes vasoconstriction in lungs. So you have more hypoxia in the lower lobes. Therefore, there will be more vasoconstriction compared to the middle zone. And in the upper zone, be the least vasoconstriction. So most blood is going to flow where? Top. The vessels to the bottom are narrow. There's not enough room for them to carry blood. The vessels on the top are dilated. So there's more blood going there. It's natural. It makes sense. Wherever you have the most oxygen, that's where your blood should go. Because the whole idea of lung is to provide oxygen to your blood. So wherever you have the most oxygen, you want to send blood there. You want to redirect and shunt it there. Does it make sense now?
Okay, I just don't understand. Why would you want to deprive the third lobe of oxygen?
I'm not depriving it.
Okay, so I'm like confused about like
Okay.
how.
Good. Let me just.
I don't
do
know.
this.
Maybe it was just me. Sorry.
No, it's me too. Okay, Irish flag or Cameroon flag. I should have done Polish flag. Okay, naturally speaking, when you have hypoxia, right? When you have hypoxia, you already know the least oxygen is in the lower lobe, correct?
Right.
Look, gas rises up.
Right.
Where do you have the highest gas? In the upper lobe, right? Because it has less gravity compared to blood. Blood flow is increased in which lobe? In the third zone, right? So how about this? Q means blood flow. Is that okay? I just want to use this term so you get used to it. I don't want to use like, I can use BF, not best friend, but blood flow, right? But I want to use Q because that's what's used. Q means perfusion. Q means perfusion. Q means perfusion. Which zone of the lung has the highest perfusion? Third. So let's put 3 arrows out of 3. Good? Are you okay with that? The second lobe zone should have 2, and the upper part should have 1. Just to kind of give you a relative ratio, right? The upper zone, zone 1, has the least perfusion. Zone 3 has the most perfusion, maximum perfusion. Are we okay with that? Okay. Now let's talk about air, ventilation. Okay, so that was for perfusion. Ventilation, V. Where would you find the most air in these 3 zones, out of the 3 zones? 1. So the most ventilation, the area of lung that has the highest amount of air or oxygen is the upper zone. Middle zone will have middle amount, and the lower zone will have the least oxygen. Is that okay? Least oxygen. This is naturally in your body. This is natural state. Let's say you have vasoconstriction. Let's say you have maybe COPD, pneumonia, whatever. Suddenly you have less oxygen available for you. Or let's say you go to a higher altitude. When you go to a higher altitude, there's less oxygen, right? When you go on top of a rocky mountain. At higher altitude, you guys should remember this from RBCs, the hemoglobin curve. At higher altitude, the amount of oxygen decreases. Partial pressure is low. So now, you have less oxygen. So in this case, you will have hypoxia. So which area is mostly affected by hypoxia? Where would you have the highest hypoxia?
Third.
Okay, so here you have the highest hypoxia, lack of oxygen. In the middle zone, you have partial hypoxia. In the upper zone, you have minimum hypoxia. My terminology is improving, good. I'm using moderate, minimum. Very nice. Good. Now, where would you have the most vasoconstriction then? Wherever you have the highest hypoxia. So you will have the most vasoconstriction wherever you have the least amount of oxygen available. Okay, so vasoconstriction will be the highest where you have the highest hypoxia. In here you will have vasoconstriction that is moderate. In the top you will have vasoconstriction that's minimum. Does that make sense? You will have vasoconstriction all over the lungs, but the maximum vasoconstriction is found in the lower lobes. So these vessels are constricted, therefore blood flow will increase, will be shunted towards the upper zone. And that should make sense to you. This is how it should be, not how it is. This is how it should be. There's no other option. Because it makes sense, wherever you have the most oxygen, most blood should go there. Right? Okay, so no blood circulation in lungs is strictly dependent on oxygen. In the brain, it's dependent on hydrogen, pH. In tissue, it's dependent on many other factors. Okay? So let's do that. What time is it? How much time do we have?
It's 10:37.
Woohoo. Woohoo. Okay, so blood flow in lungs depends on what? What's the major contributor? Oxygen pressure. Very good. In tissue, it is carbon dioxide. Major contributor. Because in tissue, the waste product is the most strongly regulated. Adenosine, which is a byproduct of metabolism, ATP. Same thing as ANP. Okay? Increased carbon dioxide, you can say it's the same thing as increase in hydrogen ion concentration. It's the same thing as lactic acid. Okay? So I hope you understand the difference between pulmonary circulation versus other tissue, non-lung tissue. Lung tissue circulation is regulated strictly by who? Oxygen. Non-lung tissue are regulated by metabolic products. Metabolic products. Products of metabolism like carbon dioxide, hydrogen ion, lactic acid, adenosine, and what else was there? 2,3-BPG. Okay. Okay. So adenosine is a strong vasodilator. A strong. Hydrogen ion is a strong vasodilator. And more than this, there's one more thing. It's known as nitric oxide. Nitric oxide is a strong vasodilator, which is a product of metabolism. Where in lungs, it's not so much. All right, so that's for that. What else do we need to know? The last thing for today, respiratory membrane, spend some time on it. This thing called respiratory membrane should be made of alveolus and capillary. Alveolar capillary. This is the respiratory membrane. So the respiratory membrane should be made of that. All you need to know is the anatomy for now. Nothing else. Capillaries are part of the alveolar wall. Capillaries are part of the alveolar wall. They're glued to it, fused to it. There's no potential space between them. So oxygen can go in and out easily. Now, so you have alveolar wall. The alveolar wall is made of what, guys? Pneumocyte 1. Very good. All epithelium are attached to basement membrane. Very good. So there should be pneumocyte 1 and there should be basement membrane. Oh, 6%. The capillary should have, it's made of endothelium, right? And endothelium is the same thing as pneumocyte 1, simple squamous epithelium. And it should have its basement membrane. So far there's 4 structures that makes the alveolar membrane or respiratory membrane. 4 structures. Pneumocyte 1, alveolar basement membrane, and endothelium, endothelial basement membrane or capillary basement membrane. Okay. Between the two, you should have a space called extracellular space, which is potential space. In this case, it's very small. Extracellular space. So at least four structures that makes the alveolar membrane. 4 structures. Within the capillary, you have the RBC. You have red blood cell. So now we'll include in this RBC membrane is another one. So oxygen has diffused through all of them. Defect in any of them can cause problem for diffusion. If the RBC membrane is stiff, it's rich in cholesterol, it's rigid, then there's diffusion for oxygen. There's a problem. If the basement membrane is damaged, more bleeding. If it's thick, that means diffusion problem. Endothelium could be thick, damaged, fibrosed, like an emphysema, diffusion problem. Basement membrane of the pneumocyte, problem. Pneumocyte 1, problem. Any of these, when they're thicker or damaged or defect, that will lead to respiratory membrane defect. And if respiratory membrane becomes thicker, stiffer, it will prevent oxygen diffusion from at the same rate as before. Okay, so you have to focus on that. So respiratory membrane, for example, in pneumonia, what happens? There's fluid. So if you have fluid, what happens to respiratory membrane? It becomes thicker. So there's a problem for diffusion. That's when pneumonia could be a problem. CHF, there's fluid, same thing. In other cases like pulmonary fibrosis, was there any medications you guys remember that caused pulmonary fibrosis? That's scar tissue. Scar tissue is very rough and it will prevent diffusion of oxygen carbon dioxide. Again, it will cause problems. Emphysema similarly. So anyhow, that's respiratory epithelium or membrane. Know the components of it. It's essential for breathing. If there's any of those components are damaged, fibrosed, whatever, it will cause problem. Yes, Rahab?
Can you go back?
Oh, go back here?
Sorry.
Okay. Done? All right. Last thing is capacities and volume. I just want to introduce you so you can memorize it for Wednesday. You need to memorize and understand all of this anatomy for Wednesday in order to understand physiology. Okay?
I assume this is not an EKG.
I hope not. It could be EKG. Why would you assume it's not EKG?
Because this patient will probably be dead.
Nope. What is this? Huh?
No,
VFib.
breathe.
VFib. So it's okay. But anyhow, the person's not dying, so don't worry, guys. Okay. Let me draw a red line in the center. Oh, I should have done that first.
I can't.
So the red line is the basal line. Okay. The amount of air that you normally breathe as you speak right now, it's known as tidal volume. Excellent. It is 500 mils. Okay, so it's this. Look, you inhale 500 and exhale 500, right? So 500. So that's tidal volume. So I'll put here volume tidal, VT or TV. If you like TV, that's fine. Tidal volume is the normal air that you breathe in and out. So you breathe 500 in and 500 out. That's tidal volume, okay? What's that? Good. So let's do this. Now, well, let's understand the total lung capacity. How much air can your lung hold at any time? Maximum air. That's total lung capacity. So going from here to here, all of this is total lung capacity.
5 liters or something like that?
Look, capacities are not volumes. Capacity is the potential of holding air. Volume is true air. Okay? Now, you see this bottom part? This is about 1200 mils of air. It's known as residual volume. It always stays in your lungs. Your lungs should never be emptied of air. Residual volume is always there in your lungs.
That's what keeps alveoli open, right?
Very good. The minimum amount of air pressure or air required to keep your alveoli open is known as residual volume. Okay, so
Minimum amounts of oxygen or air?
Just air.
air, because what you inhale, what do you inhale? Bunch of stuff. So because we don't have a mechanism to inhale only pure oxygen. I should have done.
Keep one open, that
Huh?
I wish I could tell her, but she's not allowed.
Okay. So you understand residual volume, correct, guys? Residual volume. You see this amount of air? This one, we use green. If you inhale more air compared to tidal volume, more than tidal volume, so this is the tidal volume, more than that, this will be expiratory reserve volume. Expiratory reserve volume. Okay? Expiratory reserve volume. My lines are not making sense. I should have made more room, but it's okay.
You have this diagram in your book.
Okay, so do you see where is what page?
Page 13 of Pulmonology.
Okay, so expiratory reserve volume. Do you see that? Expiratory reserve volume is the amount of air that you can forcefully expire. Okay? It's reserved for forceful expiration. Normally, you only expire how much? 500, which is tidal volume. But if you force yourself, you expire as much as you can, not without inhaling. Without inhaling. Okay? 1200. And that is expiratory reserve volume. So this reserve volume is reserved for what? For forced expiration. Okay, so expiratory reserve volume is, for example, forced expiratory reserve volume is reserved for forced expiration. And then when you use force, not natural. I mean, not spontaneous. Okay. All right. But look, from here, so if you look at total lung capacity from here to here, all of this is inspiratory capacity. Inspiratory capacity. So how much can you inspire, for example, with normal breathing?
Like 3,000 or something.
Yeah, 3,700. But anyways, don't worry about the volumes, as long as you understand. Make sure you understand total lung capacity. Do you understand total lung capacity? Okay, do you understand inspiratory capacity? Okay.
That's a quick question.
Yeah.
Does this vary for different people of all sizes? Or?
Yeah, I mean, of course, because some people have larger lungs, some have small. Yeah.
So these numbers are averaging?
Yeah. So this is inspiratory capacity. How about vital capacity? Vital capacity is the total amount of air that you can forcefully inhale or exhale. Vital capacity. It's not the same as total lung capacity. Total lung capacity is the amount of air that your lung can hold. But 1200 RV, you cannot exhale. Very good. So total lung capacity subtract RV gives you vital capacity. Okay.
When you puncture something, does that take away from the original
No. Unless.
that's like, that's always there, even if you have like a puncture.
Yeah. Yeah. So the thing is, look, lung is
Because like, I know it's not supposed to allow it to collapse, because once it collapses, it's hard to like,
see, if you puncture a lung, lungs have less pressure. Air will go from outside into lungs, not the other way around. So never will you have decrease in residual volume, because air naturally has less pressure. That's why air is coming in the first place. Okay, so you should know Make sure no inspiratory reserve volume. Make sure no vital capacity.
Can you go on for a second?
Which one?
Vital capacity.
Vital capacity, the total amount of air that you can forcefully inhale or exhale.
What about residual volume?
Residual volume is the volume that always stays in your lungs. Always.
Is that what maintains the breathing rate?
Nope. Breathing rate has nothing to do with these volumes. Normal breathing is known as tidal volume. Normal breathing, how much air do you breathe in or out as we speak? 500 mils. And what is it called? Tidal volume. How much air, what amount of air, how much air do you inhale or exhale? Let's forget this. You have the thing in your book, so I'll just tell you that way you can write it down. Look. The amount of air that you normally inhale or exhale without force is known as tidal volume. And this is usually, on average, 500 mils. Good? So that's tidal volume, normal breathing. What if you force yourself? The amount of air that you can forcefully exhale, okay, without inhaling is known as forced expiratory volume, without inhaling first. Okay? That's forced expiratory volume. But if I inhale forcefully and then I exhale, that's different. That is vital capacity. Okay? That's different because I forcefully inspired first. There's more. Total lung capacity usually should be about 68 mils, 6,800 mils, or 7 liters. 6.8 or 7 liters. Okay, that's the total lung volume. All right? So residual volume is the amount of air that you stay in your lungs all the time. And what?
Minimal volume.
Minimal volume? No, it explains residual volume.
No, it has a bar, minimal volume, and then it has like a higher bar residual volume.
Okay, so minimum volume is the residual volume, but there should be expiratory reserve volume. Expiratory reserve volume is the amount of air that you can forcefully expirate. Combination of, yeah.
I'm just asking if
There's no such thing as minimum volume. It's wrong if it's written in the book. Okay. The minimum amount of air needed to keep your lungs open is known as residual volume. It should reside at all time in your lungs. Residual volume should reside in your lungs at all time. It should never leave your lungs. Good? Forced residual, expiratory residual volume, ERV, expiratory reserve volume, is the amount of air that you can forcefully expirate or inspire in this case. So, expiratory reserve volume. This is the volume reserved for forceful expiration. This is also 1200. Residual volume is also 1200. 1200 air stays in your lung at all time. It never leaves. But you can expire 1200 extra beyond tidal volume by force. That's expiratory reserve volume. The combination of the two is known as, what do you think? Functional residual capacity. Capacity. Okay. Okay. So this is the combination of these two. So if you were thinking of that, that's known as functional residual capacity. You have the capacity to hold this much air. So tidal volume 500, correct? Now let's say on the next breath, you have this much more air. And this is how much is staying in your lung. Residual volume, right? And this from here to here, this is expiratory reserve volume. The combination of the two is capacity. But usually you don't expire this expiratory reserve volume. You only do that on forceful expiration. Normally you don't do that. So expiratory reserve volume is only done on forced expiration. Okay? Alright, and going from here all the way to the top should be inspiratory reserve volume. Okay? The combination of inspiratory reserve volume or inspiratory capacity plus expiratory reserve volume is vital capacity. There's so many ways you can do it. Just spend some time on it. Because it depends what you're adding, what you're subtracting, you can get different values. As long as you know three things you must know. Total lung capacity, vital, vital capacity, tidal volume, residual volume. These guys you have to know.
So how would a question be asked about this?
Okay. How would I ask a question is predicted. There's something known as COPD. Good? You have to know these values really, really well in order for you to answer these questions or understand them. In chronic obstructive pulmonary disease, if this is lung, air can come in, no problem. Okay, in is no problem. Leaving is dotted line less, so it's a problem. So let's say 100 mils are coming every day into your lungs, and only 80 mils are leaving every day. Over 10 years, what happens to your lungs?
They become inflated.
Yeah, because more air is trapping in. Look, 100 mils are coming in, 80 mils are leaving. That's why it means obstruction. There's obstruction to expiration. So overall, more air is trapping. So what happens to your lung? It expands. What happens to total lung capacity?
Decreases. Or no,
Increases. Very good. And you should be able to see that on chest X-ray. What happens to vital capacity? Increases. What happens to residual volume? Increases. All values increase. Except expiratory, residual, volume. Okay, so this will increase, but forced, so this will increase as well, which we don't use. Forced expiratory volume. This will decrease because your lungs are now weak. They cannot expire so much. So the problem is expiration. And when it comes to these conditions, usually a ratio is used. There's something known as spirometer. Every clinician should have in their office. It's almost like a meter for asthma, but similar. But what you do is you blow in it. If you have problem expirating, you'll measure that. So you can measure that your inspiration. So the ratio of forced expiratory volume in 1 second, 2 seconds, 3 seconds, whatever, over total lung capacity or vital capacity is decreased. And this means COPD. This is always COPD if this ratio is less.
If it's increased, then it's asthma.
Nope.
Yeah.
Asthma is also COPD.
Is it also restrictive?
Yep. Not
Oh, I mean obstructive. Sorry.
Okay. So that's where you will use it. You will use these values. No one's going to ask you what's total lung capacity. No one's going to ask you what's vital capacity. No one's going to ask you what's residual volume. We're interested how do you use them. Which means if you don't know them, you can't use them. So spend some time tonight. Make sure you understand what they mean. Okay? All right. Good enough. I'll see you guys tomorrow. No, I'm not going to see you tomorrow. I'll see you guys Wednesday.
Do we have time tomorrow?
Tomorrow is with Strict and Christine.